Welcome to our session this evening on polycystic ovarian syndrome, an update for GPs. I'm Jo Silver, I'm the GP advisor at Western Health, and we have our speaker tonight is Dr. Samina Ahmed, who's one of our obstetricians and gynecologists from Western Health. And behind the scenes, we have Yvonne from the Northwest Melbourne PHN. So next slide, please. So I'll begin this session with an acknowledgement of country. So Northwest Melbourne Primary Health Network and Western Health would like to acknowledge the traditional custodians of the land on which our work takes place, the Wurundjeri Woiwurrung people, the Boon Wurrung people and the Wathaurong people. We pay respects to elders past, present and emerging, as well as pay respects to any Aboriginal and Torres Strait Islander people in the session with us today. So just a little bit of housekeeping before we start. Everybody is muted, and if you could just ask your questions in the Q&A box. We will be recording the session, and everyone will be sent a link to the recording and a copy of the slides. So don't worry if you, don't need to worry about snapping away at Samina's slides, so as you've got a record of them. I could also just check that if you are on someone else's laptop, one of your kids, and it's got a funny name when you check your participant details, if you could just, in the chat box, just let Yvonne know who you are. And we will allocate everybody their appropriate CPD points. Next slide, Samina. For those of you who are aware, Health Pathways Melbourne have a fantastic suite of information for GPs on multiple different topics, and there is a polycystic ovarian syndrome page. So this is the PCOS page, so lots of information there. And next slide, Samina. For those of you who may not be aware of Health Pathways Melbourne, the pathways are written by GP clinical editors with support from local GPs, hospital-based specialists and other subject matter experts. They're a fantastic evidence-based source for GPs, and the aim is to reduce any variation in care, provide information for GPs on how to refer appropriately, the information that's required for referral into public and private systems. And there's also a lot of links to resources for GPs and for patients. Next. So there is a huge number of gynae and women's health pathways. So great resource for GPs, especially, some people who may not do so much women's health. I'd encourage you to have a look there. If you spend a bit of time going through the pathways, you are able to record self-log your CPD hours, the same as you would for any of your journal reading or anything else that you do. So a lot of the GPs will have been given access to Health Pathways Melbourne, but if you don't have access, you can log on to their page, send them a message and ask for access, or you can email them directly. So I'd encourage everybody to get yourself registered so you've got access. For any of the nurses or hospital or other specialists who may be on for this session, then you are also able to have access to Health Pathways Melbourne. If at the end of Samina's session, you would like to do some further upskilling in polycystic ovarian syndrome, then you can have a look at the Jean Hales Foundation website. So they've got a CPD course there that you can work your way through and do some further upskilling and increase your knowledge. So our speaker this evening is Dr. Samina Ahmed. Samina is a obstetrician gynecologist who completed her training in 2016. She has appointments at Joan Kerner Women's and Children's, the Geelong University Hospital, and also works privately at St Vincent's, Werribee and Sunshine Private. She has a special interest in fertility and extensive experience in all things women's health, and she has academic appointments at Deakin Uni, University of Melbourne, is also a supervisor with RANZCOG. Unlike me, Samina is multilingual, so that's very helpful for our patients out in the west of Melbourne who may need that extra care in their own language and culture. So I'll hand over now to Samina.
Well, thanks, Joe and Yvonne, for a nice introduction. Good evening, everyone. I'm Samina, as Joe has already introduced. I'm one of the gynecologists and fertility specialists. I would like to thank you all for taking time out of your busy schedules to attend the webinar this evening. And now, without delaying further, I will start my talk. So, as you all know, that tonight our meeting is to get an insight regarding PCOS. It's one condition where people always like to agree to disagree. Over the years, these disagreements have continued. The criteria for diagnosing keep on changing, as well as guidelines. So it's kind of a dilemma for us. And my presentation tonight is to provide clear information, assist my colleagues in decision-making, and to support optimal patient care. So I've obviously tried to introduce the disease. I would call it a syndrome, obviously, just like everyone else. The pathophysiology behind, and try to understand what happens, what disrupts the 2-cell-2 hormone theory, the associated clinical sequels, diagnostic criteria, clinical approach and treatment, mainly involving shared decision-making, and to target the approachable SMART goals. And obviously, in the end, we will take home some evidence-based targeted approach to manage PCOS-related health issues for our patients. The syndrome history goes a long way back, but was first described in 1935 by the American gynecologist Irving F. Stein and Michael Leventhal. Other names for the syndrome are polycystic ovary disease, functional ovarian hyperandrogenism, ovarian hyperthecosis, sclerosing ovary syndrome, and Stein-Leventhal syndrome. Polycystic ovary syndrome is the most common heterogeneous endocrine disorder of reproductive age women around the world, and is defined by a combination of signs and symptoms of androgen excess and ovarian dysfunction, with the clinical manifestations of menstrual irregularities, subfertility, hyperandrogenism, and long-term metabolic syndrome. Now, 50% of women with PCOS go undiagnosed. It's a big number we actually miss. 50% of these women develop type 2 diabetes before the age of 40. The disease puts a huge cost burden on different healthcare systems. As you can see, it's adding approximately $4.3 billion to American health system. Affected women have 3 times increased risk of developing endometrial cancer. Now, the pathophysiology remains unclear. Genetic basis being suspected, including dysregulation of CYP11A gene, upregulation of other enzymes in androgen synthesis pathway, insulin receptor gene on chromosomes 19p13.2, a decrease in sex hormone binding globulin. Other predisposing factors are family history of polycystic ovarian syndrome, high maternal androgen, onset of type 1 diabetes mellitus before menarche, insulin resistance, and obesity. To understand the pathophysiology behind PCOS, it is important to understand the normal autocrine, paracrine, and endocrine pathways involved in a normal physiological menstrual cycle. As you know, every month, under the influence of gonadotrophins, the recruitment of a new batch of follicles begin. So that's the journey. Every month, these follicles go through. Out of these, one follicle will become dominant and mature to undergo ovulation. The second half of the cycle is called luteal phase, which is usually fixed and 2 weeks long. During this phase, fertilization occurs, and if no fertilization, then women will get period and the cycle restarts. Whereas in PCOS, there's a disruption of this normal mechanism, and the follicles remain arrested in metaphase 1, or simply immature, and fail to develop into a mature M2 follicle, resulting in anovulatory cycles. The alteration is further explained here by two-cell, two-gonadotrophin theory. This is, I think, one of the theories which I really like to discuss with my, colleagues and students, and it explains the overall pathophysiology so beautifully. So now in this flowchart, you can see that LH receptors are overexpressed in theca cells, and in normal circumstances will help conversion of cholesterol into androgen precursors, which will undergo aromatization in granulosa cells to produce estrogen under the influence of FSH. Now, what happens in PCOS? In PCOS, LH levels are increased relative to FSH levels. Follicular arrest and increased androgen production in theca cells will occur. The most likely cause of an ovulation is an FSH level too low to fully mature the follicles. FSH levels may be suppressed by the negative feedback inhibition from the mid-follicular estradiol levels, leading to an ovulation. Insulin resistance is secondary to mutation in insulin resistance gene, leading to altered function. And 50 to 70% of the patients have insulin resistance in patients who have the diagnosis of polycystic ovarian syndrome. Now, what this resistance does? So insulin resistance causes hyperinsulinemia, and its synchronization with LH leads to hyperandrogenism. Insulin resistance also inhibits sex hormone binding globulin production, which will result in increased free androgens. And I will try to cover these, sequels which are mentioned here in coming up slides. But the main sequel of these alterations are cytological, dermatological, reproductive, metabolic, and late sequels. This is a flowchart representation of what is leading to PCOS and the clinical sequels. And after going through the pathophysiology and understanding the two-cell, two-hormone theory, I hope it is now a bit easier for you to address the elephant in the room. As I said in my introduction earlier, PCOS is a diagnosis of exclusion and is a clinical dilemma due to the controversies surrounding the pathophysiology. A number of criteria have been suggested and evaluated so far. Asia and American Society of Reproductive Medicine Rotterdam criteria from 2003 includes 2 out of the following: oligo or anovulation, clinical or biochemical signs of hyperandrogenism, and polycystic ovaries. NIH criteria in 1990 includes both oligo-ovulation and hyperandrogenism, with exclusion of related disorders. Androgen Access PCOS 2009 suggested hyperandrogenism and ovarian dysfunction, with exclusion of other androgen excess or related disorders. RCOG and most of the international bodies recommends the use of Rotterdam criteria. It's very important not to mistake PCOS with other disorders, and it's very important to rule out the other related disorders. So the differential diagnoses are hyperthyroidism, hypothyroidism, hyperprolactinemia, hypogonadotrophic hypogonadism, primary ovarian failure, acromegaly, late onset congenital adrenal hyperplasia, androgen secreting ovarian tumor, androgen secreting adrenal tumor, Cushing syndrome, and exogenous androgen use. As far as the investigations are concerned, we usually order FSH and LH. Testosterone, which should include total and free testosterone, as well as free androgen index. Dehydroepiandrosterone, thyroid function test, serum prolactin, blood sugar test, especially the 2-hour glucose tolerance test, fasting insulin level, fasting lipid profile, 17-hydroxyprogesterone, cortisol, and ultrasound pelvis. And in coming up slides, I will justify these investigations. Reliable assessment of biochemical hyperandrogenism is usually not possible on hormonal contraceptive pills. So please consider a withdrawal of greater than or equal to 3 months before testing to avoid false negative results. Now, as far as the testing for the hyperandrogenism is concerned, total and free testosterone to assess biochemical hyperandrogenism is the key in the diagnosis of PCOS. Free testosterone can be estimated by the calculated free androgen index. If testosterone or free testosterone is not elevated, consider measuring androstenedione and dehydroepiandrosterone sulfate, DHEAS. But please take into account their poor specificity and advancing age association with decreasing DHEAS. Patients with irregular menstrual cycles and hyperandrogenism, an AMH or anti-Mullerian hormone level is not necessary for PCOS diagnosis. Both clinical and biochemical hyperandrogenism persist in the postmenopausal women with PCOS. Postmenopausal hyperandrogenism symptoms should be taken care of unless other causes of hyperandrogenism, like androgen secreting tumor, etc., have been excluded. The features of hyperandrogenism are usually hirsutism, acne, androgenic alopecia, and acanthosis nigricans. For hirsutism, a modified Ferryman-Galway score has been historically used, and it depends on ethnicity. Severity of hirsutism may vary by the ethnicity, but the prevalence of hirsutism appears similar across ethnicities. Ferryman-Galway score of greater than or equal to 4 to 6 indicates hirsutism. Now, I will talk about the polycystic ovarian morphology on ultrasound and the diagnostic criteria for that. A follicle count of greater than or equal to 20 per ovary, of 2 to 9 millimeters, or ovarian volume 10 centimeter cube in adults is diagnostic of polycystic ovarian morphology on ultrasound. An ovarian volume of greater than or equal to 10 ml, or follicle numbers per section greater than or equal to 10 in at least 1 ovary in adults should be considered the threshold for polycystic ovarian morphology if using older technology or image quality is insufficient to allow for an accurate assessment of follicle counts throughout the entire ovary. No definitive criteria to define polycystic ovarian morphology on ultrasound in adolescents, hence it's not recommended. In presence of menstrual irregularities and clinical or biochemical hyperandrogenism, ultrasound is not necessary for PCOS diagnosis. However, a scan will identify the complete PCOS phenotype. As far as the clinical approach and treatment is concerned, no universal treatment for PCOS is available. Treatment is individualized and based on women's goal, severity of symptoms, shared decision-making, and SMART goals, which are mainly specific, measurable, achievable, realistic, and timely. The modalities include conservative, interdisciplinary medical team, and surgical. In this slide, I will discuss the importance of psychological screening and models of care. Prevalence, screening, and management of psychological features and models of care are common, an important component of PCOS. Women with PCOS should be asked about their perception of PCOS-related symptoms, impact on their quality of life, their key concerns and priorities for management. High prevalence of moderate to severe depressive symptoms and depression in adults and adolescents with PCOS is noted and should be screened for by using regionally validated screening tools and refer appropriately. Screening for mental health disorders compromise assessment for risk factors, symptoms, and risk of self-harm and suicidal intent. It is very important to address the psychosexual function and body image in this particular group of patients. Permission to discuss psychosexual function should be sought, noting that the diagnosis of psychosexual dysfunction requires both low psychosexual function combined with related distress. PCOS can hurt body image that contributes to above. Eating disorders should be considered in PCOS regardless of weight, especially in the context of weight management and lifestyle interventions. If disordered eating or eating disorders are suspected, appropriately qualified practitioners, including dietitians, psychologists, and other allied health practitioners, should be taken on board. Now, a brief discussion regarding achieving SMART goals. SMART goals are basically interventions to optimize healthy lifestyle and emotional well-being in PCOS patients. And these are specific, measurable, achievable, realistic, and timely goals. And they have been proven quite beneficial in achieving and retaining required targets. The above behavioral strategies include goal setting, self-monitoring, problem-solving, assertiveness training, reinforcing changes, and relapse prevention. It has been observed that goal setting for the weight loss by adopting a SMART approach and achievable goals such as 5 to 10% weight loss can yield significant clinical improvement. Dietary interventions play an important role, but there's no evidence to support any one type of diet composition over another for anthropometric, metabolic, hormonal, reproductive, or psychological outcomes. Any diet composition consistent with healthy eating will have health benefits, and professionals should advise sustainable healthy eating to individuals in accordance to their preferences and goals. It has been observed that energy deficit of 30% or 500 to 750 kilocalories per day is found to be quite effective. For weight management, anti-obesity medications, including liraglutide, semaglutide, which are both glucagon-like peptide 1 receptor agonists, and orlistat could be considered in addition to active lifestyle intervention for weight management. Please ensure concurrent effective contraception is on board in reproductive age women, as pregnancy safety data is lacking for these agents. As far as inositol is concerned, the evidence so far suggests limited harm, potential for improvement in metabolic measures, limited clinical benefits, including in ovulation, hirsutism, or weight. Shared decision-making should include discussion that regulatory status and quality control of inositol in any form can differ. Inositol alone or in combination with other therapies is still experimental, and benefits and risks currently too uncertain to recommend their use as fertility therapies. Specific types, doses, or combinations of inositol cannot currently be recommended in adults and adolescents with PCOS due to lack of quality evidence. Now a little bit about metformin. Metformin's major effect is to decrease hepatic glucose production, leading to reduced insulin secretion. Metformin should be considered over inositol for hirsutism and central adiposity. Has more gastrointestinal side effects than inositol. Metformin alone should be considered in adults with PCOS and a BMI of greater than or equal to 25 for anthropometric and metabolic outcomes, including insulin resistance, glucose, and lipid profiles. Suggested daily dose of metformin in adults is 2.5 grams and 2 grams in adolescents, starting with a low dose of 500 milligrams with a gradual increase over the weeks. Off-label use can help with oligomenorrhea, hirsutism, obesity, and prevention of diabetes, type 2 diabetes mellitus. Bariatric and metabolic surgery could be considered to improve weight loss, hypertension, diabetes, hirsutism, irregular menstrual cycles, ovulation, and pregnancy rates. Now, how to deal with hyperandrogenism, which is as we know that the common sequels of hyperandrogenism are hirsutism, acne, androgenic alopecia, and acanthosis nigricans. Self-administered and professional cosmetic therapy is first line. Laser is recommended. Eflornithine cream can be added and may induce a more rapid response. As far as the pharmacological therapy is concerned, consider if there's patient concern or if cosmetic treatment is ineffective or inaccessible or unaffordable. Should be trialed for at least 6 months before making change in dose or medication. Primary therapy is OCP and monitor glucose tolerance in those at risk of diabetes. Anti-androgen monotherapy, for example, aldactone or cyproterone acetate, should not be used without adequate contraception. And for women with contraindication for COCP therapy or when COCP are poorly tolerated. If COCP is ineffective, you can add anti-androgen to the COCP as a combination therapy. Spironolactone is widely used, and usually the doses which are in use are 25 to 100 milligrams per day. The lower doses obviously have lower adverse effects. Cyproterone acetate at doses greater than or equal to 10 milligrams is not advised due to an increased risk, including for meningioma as well. Finasteride has an increased risk of liver toxicity. Flutamide and bicalutamide have an increased risk of severe liver toxicity. The relatively limited evidence on anti-androgens in PCOS needs to be appreciated with small number of studies and limited number of participants. It is normal to have irregular cycles in first year post-menarche. Lifestyle changes, especially 5 to 10% of weight loss with structural exercise, can enable a patient to get their menstrual irregularities sorted or treated. COCP can be used in reproductive age adults with PCOS for the management of irregular menstrual cycles and hirsutism. OCPs mainly decreases LH secretion, leading to decreased androgen, and they also induce increased hepatic production of sex hormone binding globulin, leading to decreased bioavailable testosterone, which can obviously reduce the signs of the clinical features of hyperandrogenism. They also help in reduction in adrenal androgen secretion. There's no clinical advantage of using high dose of ethinyl estradiol versus low dose. 35 micrograms of ethinyl estradiol plus cyproterone acetate preparations should be considered as second-line therapy over the COCPs. Progesterone-only oral contraceptives may be considered for endometrial protection. Now here I want to highlight the importance of shared decision-making. Shared decision-making is critical while prescribing COCP to treat PCOS. Accurate information and reassurance on the efficacy and safety of the pill should be provided to improve chances of desired outcome. COCP can be used in conjunction with metformin, and it may be most beneficial in high metabolic risk groups, including those with a BMI greater than 30, diabetes risk factors, impaired glucose tolerance, or high-risk ethnic groups. Where COCP is contraindicated, not accepted, or tolerated, metformin may be considered for irregular menstrual cycles. For hirsutism, other interventions may be needed. Combination with the COCP, metformin may be most beneficial in high-risk metabolic group, as I have suggested earlier. Here I want to address the advantages of drospirenone over other progesterone. So drospirenone possesses the mineralocorticoid and endoandrogenic activities, and as a result of which, it counteracts water retention and hyperandrogenism. So it is a progesterone which we widely use to manage our patients with PCOS. In my upcoming slides, I will discuss the PCOS and its effect on pregnancy and fertility. Pregnant women with PCOS have an increased risk of higher gestational weight gain, miscarriage, gestational diabetes, hypertension in pregnancy and preeclampsia, intrauterine growth restriction, and small for gestational age babies, preterm delivery, cesarean section, and prenatal depression. Just to elaborate more, these women are at 3 to 4 times increased risk of developing gestational diabetes, 4 times gestational hypertension, 2 times preeclampsia, and approximately 1.9-fold increased chance of preterm birth, which is quite high. It is very important to advise these women prenatally about smoking cessation, optimal weight, exercise, and folate supplementations to avoid these bad outcomes. Perform glucose tolerance tests antenatally, early, and in second trimester to rule out gestational and type 2 diabetes. Advice regarding the age-related decline in fertility to allow optimal timing of family planning is crucial. I would like to discuss the role of metformin in pregnancy, as this is something which is being asked quite frequently. Metformin in pregnant women with PCOS has not been shown to prevent macrosomia, gestational diabetes, late miscarriage, hypertensive disorders in pregnancy. Metformin can be considered in some circumstances during pregnancy to reduce the risk of preterm birth and excess gestational weight gain. Women should be informed that long-term consequences of metformin exposure on the offspring is unclear, and there's a theoretical risk of increased childhood weight, though no substantial evidence is available. Side effects of metformin are mostly mild, transient GI symptoms and are not worse in pregnancy. PCOS and getting pregnant, a very difficult question. 70% of PCOS patients actually struggle falling pregnant. Most women with PCOS can achieve a natural pregnancy with lifestyle modifications, and younger patients can be reassured, but approximately 40% of women with PCOS will need infertility assistance. 70% of PCOS patients actually struggle falling pregnant. Most women with PCOS can achieve a natural pregnancy with lifestyle modifications, and younger patients can be reassured, but approximately 40% of women with PCOS will need infertility assistance. 70% of women with PCOS will need Age-related fertility discussion and planning is highly important. Letrozole is an aromatase inhibitor, which is proven effective as ovulation-inducing agent and being most widely used for this purpose. Aromatase inhibitor actually prevent the aromatase-induced conversion of androgens to estrogen, including the ovary. This mechanism, though not fully understood, but results in increased secretion of FSH, which is a follicle-stimulating hormone, stimulating ovarian follicle development and maturation, leading to pregnancy. Clomiphene citrate, which is a selective estrogen receptor modulator or SERM, is a competitive inhibitor of estrogen binding to receptors in hypothalamus and results in increased gonadotrophins and gonadotrophins release, influencing follicular growth. If we do a comparison between clomiphene citrate and letrozole, evidence has shown that letrozole should be used rather than clomiphene citrate in women with PCOS with anovulatory infertility and no other infertility factors to improve ovulation, clinical pregnancy, and live birth rates. Current evidence demonstrates no difference in fetal abnormality rates between letrozole or clomiphene citrate, ovulation induction, or natural conception. Here I would like to do a comparison between IVF versus ovulation induction. IVF can be considered in PCOS patients with anovulatory infertility if first or second line ovulation induction therapies have failed. In anovulatory PCOS, IVF is found to be effective. Risk of multiple pregnancies can be minimized by performing single embryo transfer. Women with PCOS are at increased risk of ovarian hyperstimulation syndrome due to the pathophysiology of the pre-existing syndrome and should be counseled prior to starting treatment about the additional risk, and options to reduce the risk should be discussed. Risk of ovarian hyperstimulation syndrome can be reduced by using appropriate dosage of gonadotrophins and prompt monitoring in accordance with their AMH, BMI, age, and response to the treatment. Now, here I would like to share some information regarding the state-funded public fertility care for the Victorians. This program provides 2 stimulation cycles per person at no cost and use of all frozen embryos created. Minimal cost for medication and a screening test. Couples must complete screens at GP and attach results to the referral. All referrals from the Northwest Victoria region sent to the Royal Women Hospital, and they are then triaged for the satellite clinic. For the Northwest region, the satellite clinics are mainly Joe and Karna, Sunshine Hospital, and Northern Hospital. The eligibility criteria: maximum egg age is 42 years at the time of treatment, Victorian resident, and they should have a Medicare card. Services which are currently available include fertility assessment and management, IVF, ICSI, IUI, ovulation induction, frozen embryo transfer, donor sperm and egg programs, and medical fertility preservation. Planning to be introduced in 2024 and 25, out of which some has been already introduced, are altruistic surrogacy program, genetic testing for embryos for monogenic conditions like PG4, which is called PGTM, donor embryo program. Services which are not offered at this stage are elective egg freezing, but if they have a medical reason, it can be offered. Reversal of sterilization procedures. Now, after discussing in-depth infertility, I would like to discuss here some cardiometabolic risks associated with PCOS. As we all know, after going through the pathophysiology, these patients have an increased risk of cardiometabolic. Indigenous women have a higher prevalence of these risk factors and are more prone to encounter PCOS-related complications at much younger age than non-Indigenous women. 75% of lean body women with PCOS will have insulin resistance, and approximately 50% can develop metabolic syndrome. As I have discussed earlier, the lifestyle changes with greater than 5% weight loss in these patients who are overweight reduces their diabetes risk by approximately 50 to 60%. Metformin reduces the risk of diabetes by approximately 50% in adherent high-risk groups. The pill is indicated for contraception and metformin for diabetes. The combined use is supported by evidence and is recommended by the international and national specialist societies and is evidence-based to combat insulin resistance and hyperandrogenism in patients with PCOS. Few things about obstructive sleep apnea. The evidence suggests that PCOS patients have significantly higher prevalence of sleep apnea compared to women without PCOS, and it's independent of their BMI. PCOS patients should be assessed for symptoms if present, screened with validated tools, or referred to respiratory physicians for further evaluation. Berlin questionnaire is a validated tool in general population and can be used in PCOS patients as well. Formal diagnosis requires a sleep study. Treatment should be tailored according to individual needs and goals. PCOS patients have a higher risk of developing endometrial hyperplasia and endometrial cancer due to chronic exposure to unexposed estrogen. Long-standing untreated amenorrhea, high weight, type 2 diabetes, and persistent thickened endometrium are additional to PCOS as risk factors for endometrial hyperplasia and endometrial cancer. Overall, chance of developing endometrial cancer is low. Therefore, routine screening is not recommended in PCOS patients. Preventive measures, including lifestyle modifications, cycle regulation, and progestogen therapy, can reduce the risk. When increased endometrial thickness is detected on ultrasound, consider a histological diagnosis in the form of a biopsy. Now, this is my live slide, and I would like to conclude my talk tonight with the following take-home messages. Polycystic ovarian syndrome is one of the most important endocrine disorders that affect females in the reproductive age and may lead to serious complications. Further studies are needed to determine the exact etiology of PCOS, methods of prevention, and proper management. PCOS is an endocrine disorder associated with hormonal and menstrual abnormalities. It may be associated with short and long-term complications. Diagnosis involve clinical, laboratory, and radiological methods. Treatment depends on the need of the patients and the severity of the symptoms. Treatment can be conservative, medical, or surgical, incorporating shared decision-making and smart approach. Thank you very much for your time. And Joe, if there are any questions, I'm more than happy to answer.
Thanks, Samina. That was a fantastic overview of a condition that's very common. And I think, you know, in our GP world, there's lots of multi-system disease that goes on. And I think it's, you know, important that we try and tie it all together, and it can be really quite challenging for a lot of patients. You know, I think they get focused on, you know, the cycle problems and the hirsutism, but and you know, for some of them it's the fertility issues, but for us GPs, we need to be quite vigilant about all the other the body impacts on other organ systems.
Yes, yes. I mean, you see the late sequels, the metabolic syndrome, like you start as a very young person with PCOS and you end up with all these complications later in the life,
Yeah.
So yeah, so it's a lifelong problem, I think so. It needs to be addressed. Thank you very much.
So we've got a few questions. So first question is, does hormone testing need to be timed in relation to the patient's cycle?
All right. I think that's a very good question and tricky one as well. So as we know that patients with PCOS, they usually have menstrual irregularities. So it's very difficult to time the test according to their cycles. So my approach usually in those, my approach and obviously the evidence approach is the same, is that if you can't predict the cycles, the test can be done anytime. But if you are giving them, like, for example, withdrawal bleed in the form of a Pramalute or something just to help them with the period, then they can actually do the test on day 2 or 3 of their periods. But if they are basically having a period every 3 months or 2 months or something like that, and they think that they might get a period, then I think day 2 or 3 is a better day to perform these tests. But if they're not getting periods, then I think you can do the test regardless.
Great, thank you. Now this is a tricky one too. Can polycystic ovarian syndrome be diagnosed in girls with primary amenorrhea?
Yes. So as I said, I don't know whether you were there when I was talking about the adolescent group. So if they have primary amenorrhea, I think it's very important to rule out other causes, like whether it's a hypo, like hypogonadotrophic hypogonadism, or it's basically a primary ovarian failure. What's their karyotype, what's going on. So I think so we need to rule out a lot of differentials before labeling these patients as PCOS, especially young girls with primary amenorrhea. So there might be something else going on, but obviously it's a diagnosis of exclusion. So you have to exclude all other related, differentials before diagnosing them with PCOS. I have hardly seen anyone with primary amenorrhea being diagnosed with PCOS in my clinical practice. If you have, please share the details.
Thank you. So with the patient who has a high BMI and may well have the pill as is contraindicated, so the combined pill, can you talk a bit about what you would use for them if they wanted to have some, if they wanted the menstrual cycle, or if you wanted to give them some endometrial protection?
Yeah. So I think so then in that case, we will come down to progesterone only options. So we have got a wide range of progesterone only options to not only provide them contraception benefit, but also for their endometrial protection. So we have the option of progesterone only pill, which is being marketed with the brand name of Slenda these days. It has got drospirenone, which is, as I said earlier, has got both anti-mineralocorticoid and anti-androgenic activities. So it's basically help with the hirsutism and bloating and all of that. So this is one of the pill which is available. You can also use microlute, but microlute hasn't been proven like quite effective in high BMI women. We have other options, like we can also go for implant, and we can also consider Mirena for the endometrial protection and contraception.
All right. Can you talk a little bit about the use of cyclical Primalute in some of those women who, is that an option as well?
Yeah, this is an option as well. So for endometrial protection, we actually recommend at least 6 to 8 cycles per year. So I think 6 cycles are adequate. So if these patients are not willing to, or if you have discussed in depth and detail, and they are not willing to start any of these other agents for the endometrial protection and contraceptive purpose, then they can definitely have a withdrawal bleed. But obviously they need to see their GPs regularly to get the script maybe every 3 months or 4 months, so that just to make sure that nothing else is going on. And frankly speaking, I would also recommend ultrasound in this population, because there's a possibility of developing endometrial hyperplasia or seeing cystic changes in the lining of the uterus. So I think it's important to monitor these patients. Maybe an early scan should be enough, but this is how I think the monitoring can be scheduled for this group of patients.
Great, thank you. So another question about contraception. Can you please reiterate your preferred combined oral contraceptive pill for PCOS and its rationale? So that's part one. And then part two of that question, can you discuss options for patients with migraine? Can they use progesterone only? I think you may have addressed some of that already.
Yeah, thank you very much. So I will answer the part one of this question first. Very good questions. As far as my preferred choice is concerned, the evidence is suggesting there's no difference between the usual, pills which are available and the pills which contain, cyproterone acetate or some other progesterone. To be honest, all of us know that some of these pills, which are basically, which we think are going to work better for, traditionally are going to work better for PCOS, they're basically not on PBS. So it's quite expensive treatment for the patient. So I usually start with the normal pills according to the evidence. And if the patients are not responding well to those routine, pills which we use, then you can move up to Estel or Dine35 or Zoeli or whatever you think, with different type of progesterone and different, usually between 20 to 35 micrograms of ethanyl estradiol. But in my clinical practice, I usually start with PBS label, cheap contraceptive pill to begin with lifestyle modifications. And most of the times it works. But if having trouble, then you can actually go for something like Dine35 or Estel.
Great, thank you.
I'm sorry, there was a part B as well.
And the part B was, please discuss options for patients with migraine. Can they use the progesterone only?
All right. Yes, you see, obviously with migraine, our preferred choice is progesterone only, but I think it's very important to know the causes behind migraine. So I come across a lot of women these days who were used to have migraines because related to work, or they had some focal functional cause of those migraines, not related to hormones. So if that is the case and they haven't had migraines for a long period of time, so I don't think so. There's no harm in trialing the routine, low dose pill for them. I'm talking about low dose estrogen containing pill for them to begin with. And if they are responding well and the migraines are not coming back, I think so just continue with that. But if the hormone was related, the migraines were related to a focal cause or which was basically hormonal imbalance or something, and they're expecting it to come back, then maybe just avoid it and just do the routine progesterone only contraception of method.
Right, thank you. Now, a pregnancy-related one. How early in a pregnancy should you do a glucose tolerance test in a patient who's got PCOS or other women at high risk?
Okay. So usually we actually recommend PCOS patients to have, when they are obviously trying to have a baby, and I think I would request GPs to do a glucose tolerance test prenatally. But if they have entered pregnancy, we usually recommend a PCOS after 14, we usually recommend a glucose tolerance test after 14 weeks. That is the early OGTT. And then, but if you have got a patient who is really high risk and you're worried about the glucose intolerance, you can do it earlier in the pregnancy, like earlier than 14 weeks. That's completely fine. But we usually recommend after 14 weeks by the time we see them. But in your practice, if you're worried, the patients have really high risk factors, high BMI, other things going on, you already know that patient is insulin resistant, you can do it earlier than that. The problem is that early pregnancy, the patients have a lot of hyperemesis. They most of the times are unable to tolerate the glucose tolerance test because it involves drinking a glucose drink, which they usually vomit out because of the hyperemesis early pregnancy. So yeah, we usually recommend it around 14 weeks of gestation onwards, and then we do the second one in second trimester.
Yeah, so the 26-week one that they ordered. So yeah, it's great if the GPs are doing those maternity referrals and they've got a patient who's a higher risk. If once you've done your first trimester sort of aneuploidy screen, you've got a viable pregnancy then, and often then the hyperemesis has settled a bit, and if you can get the patient to do a glucose tolerance test and send that in with the referral, that's fantastic. You'll get extra.
Yeah, agree.
that. Yeah. Now, do the patients with PCOS have gastrointestinal syndromes and food intolerances? Do they have increased incidence?
I am not sure about it, that they have food. Sorry, Joe, can you repeat the
Yeah,
question?
so do they have an increased incidence of GI syndromes or food intolerances? I'm sure, there's definitely a group who have increased risk of irritable
Yes,
bowel,
because
which I guess is sort of some of
yeah, because I think so they struggle with their with the hyperinsulinemia and deranged liver functions. So
Mm.
I will not be surprised if they struggle with with these problems, but I think it's important to exclude other causes as well.
Thanks. Another question. I know that depression is a significant risk also, I think 7 times or so compared with other women. Do you know if the suicide rates are higher?
Yes, to be honest, the suicide rates are higher, and I think in my the slide where I was actually discussing about the psychosexual impact, it's mentioned that they have higher risk of suicidal, intentions, and there's a bit higher risk of societal attempts and suicide in this particular group because of the body imaging and psychosexual impact on overall and affecting the overall quality of life.
Thank you. Another question, you may have answered some of this. If a patient has a contraindication for the combined pill, what's the next option for a regular cycle?
Yeah, you can do a progesterone only method. So with the microlute, so you see there's a difference between microlute and Slenda. So Slenda has drospirenone, which works quite similar to Marina. So which is levonorgestrel. Then I usually have a discussion with my patient, and that's where the shared decision making, actually comes in. If they're actually looking forward to regulate their periods and to have a regular cycle, maybe microlute is a better option as compared to drospirenone, because with drospirenone, they are going to have a reduction in the flow, and most of the times they like approximately 25 to 30% of the patients stop having periods, just like Marina. So if this is not their goal, they want to have a period, then I think microlute as a progesterone only option is a better option as compared to all other progesterone only options currently available in the market.
Thank you. Now another question.
But just sorry to interrupt you, but just keep in mind the high chances of breakthrough bleeding with microlute.
With microlute, yeah. And Slender, unfortunately is more expensive. So
it's expensive. You just only get one strip, and I think it's quite expensive. So people, I think if I usually do Slender as a trial. So I just ask my patients to start Slender, because a lot of these women have psychosexual and ADHD and mental health concerns as well. And that progesterone can impact their mood and other stuff. So I usually start Slender as a trial because it's easier to stop. And if the patients are feeling okay with Slender, usually I switch to Marina afterwards if they are okay with that. So because I've come across, and we know that it's quite expensive brand.
Yeah, which is an issue, isn't it?
Yeah.
Eflanorthine cream, is it used for acne, hirsutism, or acanthosis nigrans, or alopecia? So I guess that's the we used to have it in Australia. It was called Vanqua. I don't think it's available anymore, but I think you can get it compounded.
You can get it compounded, and to be honest, I also can't prescribe it. If I have a patient, I usually refer them to a dermatologist.
And it's used for hirsutism.
Yeah.
Okay. Another question. Is it better to start treatment with a combined contraceptive pill then later add metformin if it's necessary? Is that what if so?
Sorry?
If you're going to start treatment, would you start treatment with combined contraceptive pill and then consider adding metformin?
Again, it depends on, patient's preferences. So if a patient is looking forward for a contraception, then obviously and has a BMI of less than 25, like normal BMI patient looking forward for contraception, and his hirsutism effective management, maybe we can start with the pill, which will address both. But if they are higher BMI and they are not looking forward for contraception, planning a baby in near future, then maybe I think metformin only should be your call.
Thank you. Another question, what time frame after menarche can you expect periods to, if you've got somebody who's got irregular periods, would you then consider investigating for PCOS?
Okay, so you see, 1 year post-menarche, you don't need to worry about. 1 year post-menarche, if they have irregular periods, it's completely fine. 3 years is a long period. So if someone is still getting abnormal or irregular periods for a period approximately of 3 years, then it's a time to start investigations.
Thank you. And I think people can have a look at the Rotterdam diagnostic criteria. Has got quite detailed explanation of
Yes.
how to approach the adolescence and irregular cycles and timeframes. So,
yes.
And
then it has also given a very good, like, that if they have they are having less than 8 cycles in a year, then it's time to start rolling the investigation. So the new Escherman Escher guidelines, Escher and ASRM guidelines 2023 are a very are I think very good to address all these confusions and controversies.
Yeah, step yourself through it. Don't get sort of too tied up. And I think, Samina, did you want to comment on ultrasounds in adolescents looking at for cysts? So
yeah, so again, in adolescence, the role is controversial. 1 year till like post-menarche, no role. When you're starting investigations, yeah, you can perform, because obviously PCOS is the diagnosis of exclusion. You don't want to miss androgen secreting tumor or ovarian tumor, which is secreting androgen. So you don't want to miss out on all of these things. So I think just to complete the overall PCOS phenotype, you can include it. But as such, there's no role if you have a clear picture of PCOS in front of you.
Yeah.
But I would still like to do it just to complete the whole
picture.
Yeah.
Another question, so jumping around a little bit here. Do we have to give microlute cyclically?
Depending upon what's the patient's preferences are. If they want to have, period every month, obviously they need to continue on with the pill, and when they're on the pill, they will get a period every month. That's usually what we suggest to the patients. But if they want to skip the periods, they can skip the sugar pills.
I guess microlute doesn't have the sugar.
No, it doesn't have. So they just need to be on the pill.
They just need to continue on.
They just need to continue.
Yeah, and they may get breakthrough bleeding, or they may get a regular period. It's a bit unpredictable, isn't it?
That's one of the things which usually this is one of the factors which is responsible behind discontinuing microlute in most of the patients. Because that breakthrough bleeding is so unpredictable.
Yeah, they don't thank you for it. Another final question here. How quickly would you titrate up metformin doses for PCOS? Obviously, depending on GI symptoms. If a patient is tolerating it, I understand that maximum dose is 2.5 grams in adults daily, as per your slide. Also, would you split the dose or not during the day? So,
you see, I usually start with 500 milligrams. That's what being recommended. And then usually I ask them to start it in the evening with some food because of the GI effects. And then gradually increase it, like maybe depending upon how the patient is tolerating it. And everyone is different. So I usually ask my patients that if you have tolerated 500 milligrams well for a week, then increase it to 1 gram the following week. And it frankly speaking depends on what dose your patient is actually stabilized. most of the patients are stabilized on a dose between 1.5 to 2 grams. So most of the time, you're not required to go beyond 2 grams. I hardly go beyond 1.5 gram because most of my patients usually respond well somewhere in between 1.5 to 2 grams. So you are evaluating these patients on a regular basis. So it is recommended that it is advisable that you can go up to 2.2 or 2.5 gram, but in most circumstances, you don't need to go that high.
And do you use the slow release formulation or? Yeah.
Yes, yeah. It acts well.
Yeah. Okay. Good. And I just had another question. This is my one. So if a patient's got PCOS and they're on metformin and they conceive, what should the GP do if that patient presents in their rooms? So, there's a panic. Do I stop it or do I leave it on and send tell them to keep going and send the referral in?
Yeah, you see that's what I especially address in one of the slides, Joe. But anyways, I'll repeat it again for you. So this is a frequently asked question from GPs, and especially with us as well, because as fertility specialists or as gynecologists, we love metformin, most of our patients fall pregnant while they are on metformin. So the evidence is actually not sufficient enough to tell us or guide us, but it's saying, the disadvantage, the theoretical disadvantage of continuing metformin is the childhood weight gain and the problems with the child, like the child can get maybe excessive weight and things like that later in their childhood. So usually the evidence beyond 12 weeks is definitely missing. So we usually don't ask them to continue the metformin throughout the pregnancy, which I think would be more problematic. But if your patient is on metformin, has PCOS, you have treated them for fertility, they fall pregnant while they were on PCOS, I think there is no harm in, this is coming from me, basically, it's because the evidence is really insufficient. I don't think so there's no harm in continuing metformin and progesterone through the 12 weeks of pregnancy. And then after that, obviously, you can stop it. But I think that if they're on metformin and they have conceived on metformin and they're already on progesterone or not, depending, I think metformin can be continued at least till you have a dating scan where you have seen the viable pregnancy. Then you can stop.
Yeah, and then the decision will be made by a specialist.
Yeah, by specialists. And we see a lot of patients these days, and maybe you've come across where endocrinologists have continued metformin for the pregnancy.
Yeah. Well, that's great. Well, thank you, Samina, for a fantastic session.
Thank you.
Lots of information there for us all to take home and sort of look at what's happening in our own practice and continue to improve care and option for these patients. So thank you for all the work you've done in preparing this session for us and presenting tonight. And thanks to Yvonne behind the scenes.
Yes, thank you, Yvonne.
Yeah, and everybody will receive the email with the recordings. And please, if you can provide the feedback to us. So I think Yvonne will send out that as well. Is there another slide, maybe?
Yeah, actually, we have got slides regarding, I have got some slides with references and resources. What happened? Yeah, so there's some references and there's actually a lot of references and some resources, and then we have got this.
That's right. So, so if you can provide us your feedback for the session, that would be fantastic, because we always like to know what people, what education you want going forward. The women's health sessions are always popular, so that's been great. But whatever else you feel that you would need, that we can see what the specialists we can have available to help us with our education program. So, and thank you everybody for giving up your evening. Thanks, Samina and Yvonne.
Thank you.
Yeah. Oh, I've lost you, Yvonne.
I can still see Yvonne.
Yeah, she's talking, but I can't hear her. Anyway.
Okay.
All right.
Thank you so much for a great session.
All right. Okay. Thanks, everyone.
Thank you.
Good night.
Good night.
Good night. Good night.